one or two of you can keep interacting with me. So I'll begin now. Okay. So today we are going to briefly discuss about the diseases of external ear. Is that clear?
Yes, sir.
Okay, so external ear includes diseases of pinna and diseases of external auditory canal. Okay, so we'll be touching upon the important ones one by one. First, the diseases of pinna. So a brief recapitulation of whatever you have learned in your anatomy class or anatomy of external ear. Okay, so pinna, it has got fossa triangularis, the lobule, the tragus, antitragus, okay? And then cavum concha, helix, antihelix, cyma concha, above the cavum concha, fossa triangularis, and the crura antihelix, okay? So just below the undersurface of helix, there is scaphoid fossa. So this is brief recapitulation of anatomy of pinna. Clear?
Yes, sir.
Okay.
Yes, sir.
Okay, so first the congenital disorders of pinna. First one is bat ear or lobe ear, okay? So this is nothing but an abnormally protruding ear. Then the second one is preauricular appendages, okay? The skin covered tags that appear on a line drawn from the tragus to the angle of mouth. So there will be skin covered tags that will appear on a line which is drawn from the tragus to the angle of mouth. So that is preauricular appendage. Then we have preauricular pit or sinus. It is commonly seen at the root of helix and is due to incomplete fusion of tubercles. So when the ear is developing, embryologically there will be tubercles, okay? So if they are not fusing completely, then you get preauricular pit or preauricular sinus. Anotia or anosia, that is complete absence of pinna. Macrotia or macrotia, it is, as the name suggests, an excessively large pinna. Then we've got microtia or microsia. Okay. This is a major developmental anomaly. It is frequently associated with anomalies of external auditory canal, middle and internal ear. It is important because it is also associated with anomalies inside. This condition may be unilateral or bilateral, and it is often associated with hearing loss. Am I audible?
Yes, sir. Yes, sir.
Okay. So these pictures, you can see these are all developmental anomalies, okay? So preauricular tags, you can see on your right side of the screen, top one is preauricular tag, okay? Then below that is complete absence of pinna, anotia, preauricular sinus on the left side, and on the top there is duplication of pinna. So this is a developmental anomaly where the pinna has not developed properly. Now we come to trauma to the pinna or trauma to the auricle. Okay, so the first one is hematoma of the auricle. Okay, just a second, I'll just get back. Just a second, I'm just going to fix a small problem over here, okay? Okay, now can you hear me?
Yes, sir.
Yes. Do you also see me in a small window? Does a small window pop up on your computer screen where you can see me? No?
No, sir.
You're just seeing the PowerPoint?
Yes, sir.
Okay. That's also fine. Okay, trauma to the pinna or trauma to the auricle. Okay. So that includes first hematoma of the auricle. Okay. So it is, as the name suggests, a collection of blood between the auricular cartilage and its perichondrium. So between the cartilage and perichondrium, if there is blood, whenever there is a trauma, that is known as hematoma of the auricle. It often results from blunt trauma, and it is seen among boxers, wrestlers, and rugby players. Okay, the extravasated blood, it gets clotted, it organizes, resulting in a typical deformity, which later follows. Okay, and is known as cauliflower ear. And if the hematoma gets infected, it results in perichondritis. So what you should understand is active contact sports that could lead to hematoma of auricle, which can complicate to cauliflower ear, and if it gets infected, it leads to perichondritis. So on your top left, so you can see a cross-sectional diagram. Okay, the skin is there. There is devascularized cartilage, and that red thing, that is blood clot just below the perichondrium. Okay, normally there is no such blood clots, but after trauma, then it can get collected like this. So on your right side, there is hematoma. Okay, and you can also see a small incision which has been made upwards in order to release or drain the blood. So if it gets complicated, then later it forms cauliflower ear, okay, which is shown with an arrow. So treatment, first we try aspiration. Okay, we get a wide bore needle and then aspirate whatever is accumulating inside. After that, we put on pressure bracing to prevent reaccumulation. If the aspiration fails, then we need to do incision and drainage and apply pressure bandage. Okay. After that, we give prophylactic antibiotics. So keeping in mind that the cartilage is in close contact and that there could be perichondritis, we often give proquinolones, okay, ciprofloxacin group of drugs. Lacerations, they are repaired as early. Lacerations is whenever the pinna gets lacerated. Okay, they are repaired. They have to be repaired as early as possible. Then avulsion of pinna. When pinna is still attached, primary reattachment should be considered, and it is usually successful. Okay. So completely avulsed pinna, it is re-implanted by microvascular techniques. And in others, the skin of the avulsed segment of pinna, it is removed and cartilage is implanted under the post-auricular skin for later reconstruction. So these are different techniques of treating avulsion of pinna. Then another entity is frostbite. Okay, frostbite in cold weather, there could be frostbite. The injury frostbite varies between. There could be mild erythema, which is redness, and edema, which is swelling. It could further aggravate into a bulla, okay? And then if it happens for a long time, then there could be necrosis of the skin first, followed by necrosis of subcutaneous tissue, and then complete necrosis with loss of the affected pinna. So all these can happen due to frostbite. Frostbite will cause necrosis, okay, in an extreme level. So treatment is because of cold. Because of cold, the blood vessels have constricted and the pinna has been deprived of its nutrients and blood supply. Okay, so the treatment includes rewarming with moist cotton plaitets, rewarming with moist cotton plates at temperature of 38 to 42 degrees centigrade, application of silver nitrate 0.5% soaks for superficial infection, analgesics for pain, rapid rewarming of frostbitten air causes considerable pain. Okay, so if there is bulla, then we have to protect them from rupturing, and we need to give systemic antibiotics for deep infection. Okay, and if it is necrosed already, then we need to give surgical debridement. Are you guys following?
Yes, sir.
Okay, so that was frostbite. Okay, the next one is keloid of auricle. So keloid, you can see usually among young girls who would prefer to pierce their ear, okay, especially at the level of cartilage. Okay, so it follows trauma or piercing of the ear especially for ornamental purpose. The usual site are the lobule or helix. Surgical excision of the keloid usually results in recurrence. Okay, so you not only excise it, but you also give local injection of steroid after excision. We usually give triamcinolone. Okay, and then previously radiotherapy was used for recurrence, but nowadays we usually give steroids. So this is an example of keloid. Okay, now inflammatory disorders. First one is perichondritis. Okay, this sometimes is asked as short notes, perichondritis. So it results from infection secondary to lacerations, hematoma, or surgical incisions. It can also result from extension of infection from diffuse otitis externa or a furuncle of the meatus. And if you do culture and sensitivity test, then usually we get Pseudomonas and mixed flora. Okay, so the main culprits of perichondritis are Pseudomonas and mixed flora. So the clinical features, initially it will be red, hot, the pinna will be painful and stiff. Later, there could be formation of abscess between the cartilage and perichondrium with necrosis of cartilage. Okay, and treatment, we need to give systemic antibiotics for perichondritis, and local application of 4% aluminum acetate compresses have to be given. If there is already an abscess formation, then we need to do incision and drainage. Okay, so the preferred site would be wherever we have the natural fold of the pinna, we need to make an incision and drain the abscess, followed by bandaging. Okay, then there is something known as relapsing polychondritis. Okay, it is a rare autoimmune disorder involving cartilage of the ear. Other cartilages, septal, laryngeal, tracheal, costal may also be involved. The entire auricle except its lobule becomes inflamed and tender, and external auditory canal becomes stenotic. Okay, so it is a rare part of autoimmune process. So not only the cartilage of pinna, but the cartilages of different parts of the body, like nasal septum, larynx, trachea, and intercostal cartilage can also be involved. And treatment is high doses of systemic steroids. Okay. Then there is an entity known as chondrodermatitis nodularis chronica helicis. The name itself is long, but if you try to divide it, then you get an idea as to what it might be. Okay, small painful nodules appear near the free border of helix. So it affects men about the age of 50 years. Nodules are tender and the patient is unable to sleep on the affected site. Okay, treatment is excision of the nodule with its skin and cartilage. So you excise the nodule as well as skin and cartilage. Okay, those were some of the common diseases of pinna. Now the next part of external ear is external auditory canal. Okay. So is everybody following?
Yes, sir.
Okay. So diseases of external auditory canal. First, congenital disorders. The atresia of external canal. As the name suggests, atresia means that is absence of canal or narrow canal. Okay. So it may occur alone or in association with microtia. It is due to the failure of canalization of the ectodermal pore. The outer meatus is obliterated with fibrous tissue or bone, while the deep meatus and the tympanic membrane are normal. Okay, atresia with microtia is more common. It may be associated with abnormalities of the middle ear, inner ear, and other structures. The next is coloidal fistula. This is an abnormality of the first branchial cleft. There are two openings, one situated in the neck just below and behind the angle of mandible, and the other in the external auditory canal or the middle ear. The tract of fistula traverses through the parotid in close relation to the facial nerve. Now the inflammations of the ear canal. So basically, inflammation of ear canal is known as otitis externa, and it is a short node on itself. Okay, it is divided on etiological basis into infective group and reactive group. Okay, so the infective group includes bacterial, which is localized otitis externa or furuncle, diffuse otitis externa, and malignant otitis externa. Each one of them can be asked as a short node. Okay, so this is very important. Fungal otomycosis. Otomycosis again is a short node. And then we have viral herpes zoster oticus, again short node, and otitis externa hemorrhagica. Okay, so this is very, very important. And on the reactive side, we have eczematous otitis externa, seborrheic otitis externa, and neurodermatitis. So first, furuncle or localized acute otitis externa. Furuncle is a staphylococcal infection of the hair follicle. It is seen only in the cartilaginous part of meatus, because only the cartilaginous part of meatus will have a skin lining, and for furuncle to develop, there has to be an infection of the base of the hair follicle. So it is usually single, but sometimes it can also be multiple. Clinical features: severe pain and tenderness, which are out of proportion to the size of furuncle. Furuncle will be small, but pain will be very, very severe. Movements of the pinna are painful. Jaw movements, as in chewing, also cause pain in the ear. So if the furuncle is on the posterior meatal wall, it causes edema over the mastoid bone with obliteration of the retroauricular groove. So because it is a bacterial infection, there could be enlargement of periauricular lymph nodes, and they will be tender. Treatment: in early cases without abscess formation, we need to give systemic antibiotics, analgesics, and local heat. An ear pack of 10% ichthyamol glycerin provides splintage, reduces pain. It is hygroscopic. That means it draws fluid from the skin as well as through the inflamed area, and it reduces edema. And ichthyamol is also mildly antiseptic. So if abscess has formed, we have to do incision and drainage. So in case of recurrent furunculosis, diabetes mellitus should be excluded, and attention to the patient's nasal vestibules, which may also harbor staphylococci, and the infection transferred by patient's fingers. Staphylococcal infections of the skin as a possible source should also be excluded and suitably treated. Then there is something known as diffuse otitis externa. As the name suggests, there is diffuse inflammation of the meatal skin, which may spread to involve the pinna and epidermal layer of tympanic membrane. Etiology, it is seen in hot and humid climate and in swimmers. The sweating changes the pH of meatal skin from that of acid to alkaline, which favors growth of pathogens. The factors responsible are trauma to the meatal skin and invasion by pathogenic organisms. So trauma can result from scratching the ear with hairpins or matchsticks, unskilled instrumentation, vigorous cleaning of ear canal after a swim when meatal skin is already macerated. Common organisms are Staph aureus, Pseudomonas, Escherichia coli, or mixed infections. And it can also be secondary to infection of the middle ear or allergic sensitization to topical ear drops, which are used for CSOM. Okay, so it could also be because of allergic reaction to some of the topical ear drops. So clinical features in acute phase, there will be hot burning sensation in the ear, followed by pain, which is aggravated by movements of the jaw. Then there will be thin serous discharge, which later becomes thick and purulent. The meatal lining becomes inflamed and swollen. There will be conductive hearing loss, and in severe cases, there will be lymphadenitis. In chronic phase, there will be irritation and strong desire to itch, which is responsible for acute exacerbations and reinfection. Discharge is scanty and may dry up to form crusts. Meatal skin, which is thick and swollen, may also show scaling and fissuring. Rarely, the skin becomes hypertrophic, leading to meatal stenosis, which is known as chronic stenotic otitis externa. So treatment for acute phase, first we need to do ear toileting. All exudate and debris should be meticulously and gently removed. And special attention should be paid to anteroinferior meatal recess. So we do dry mopping and we clear the debris or whatever is there with a suction, that is known as suction clearance, or sometimes we irrigate the canal with warm, sterile, normal saline. Then we put medicated wicks. Gauze wick soaked in antibiotic steroid preparation is inserted in the ear canal, and the wick is changed daily for 2 to 3 days. Then we give steroid ear drops after removing the wick. Aluminum acetate 8% or silver nitrate 3% are mild astringents and can be used in the form of a wick to form a protective coagulum to dry up an oozing meatus. So broad spectrum systemic antibiotics are given and analgesics for relief of pain. For chronic phase, the aims of treatment includes reduction of meatal swelling so that ear toilet can be effectively done and alleviation of itching. So again, we give a gauze wick soaked in 10% ictamol glycerin, ear toileting, and topical application of antibiotic steroid cream. Surgical treatment is usually required for chronic stenotic variety of otitis externa. The stenotic part is surgically excised and bony meatus is widened with a drill and lined by split skin graft. So are you guys following?
Yes, sir.
Yes, okay. So that was about otitis externa, bacterial ones. Okay, then we have otomycosis. This is a short note in itself. It is fungal infection of the ear canal, mainly caused by Aspergillus niger, Aspergillus fumigatus, or Candida albicans. It is seen in hot and humid climate of tropical and subtropical countries. There will be secondary fungal growth in patients using topical antibiotics for treatment of otitis externa or middle ear suppuration. So it could also be because of secondary fungal growth. Clinical features: intense itching, discomfort or pain in the ear, watery discharge, musty odor, and ear blockage. So they appear white, brown, or black and has been likened to a wet piece of filter paper. So on otoscopy, when you actually see with an otoscope, you get black-headed filamentous growth inside the external auditory canal if it is Aspergillus niger, pale blue or green in case of fumigatus, and if it is Candida, then you get white or creamy deposit. The skin appears sodden, red, and edematous. So this picture shows black filamentous growth, otomycosis due to Aspergillus niger. Treatment: we need to do thorough ear toileting to remove all distal and epithelial debris. It can be done by syringic suction or mopping. So first you have to remove whatever the fungal debris is present in the external auditory canal, and after that you give 2% salicylic acid in alcohol, which is a keratolytic agent that removes superficial layers of epidermis. Along with that, the fungal mycelia growing into them will also be removed. Specific antifungal agents can also be applied. You can get ear drops of clotrimazole. Okay, you can also give nystatin or povidone. So the basic idea is that even after the apparent cure, in order to avoid recurrence, the antifungal treatment should be continued for up to 1 week, okay, even after there is apparent cure. Ear must be kept dry, and then you have to give antibiotic steroid preparation. Then there is another entity known as otitis externa hemorrhagica. So it is characterized by formation of hemorrhagic bulla on the tympanic membrane and deep meatus, probably viral in origin, and is seen in influenza epidemics. So clinical features: severe pain in the ear, blood-stained discharge when the bulla rupture. Treatment is analgesics, and antibiotics are given for secondary infection if the bulla has ruptured into the middle ear. This is otitis externa hemorrhagica. Then eczematous otitis externa. It is due to eczema or hypersensitivity to infective organisms or topical ear drops, such as chloromycetin or neomycin. It is marked by intense irritation, vesicle formation, oozing, and crusting in the canal. So some eardrops will not suit to some patients, and that indeed will cause otitis externa itself. That is eczematous otitis externa. And the treatment will be withdrawal of topical antibiotic causing sensitivity and application of steroids. Okay, whatever you're giving, you have to stop that and you give steroid cream. Seborrheic otitis externa. It is associated with seborrheic dermatitis of the scalp. Okay. Itching is the main complaint. There will be greasy yellow scales in the external auditory canal over the lobule and post-auricular sulcus. So treatment is ear toilet, application of a cream containing salicylic acid and sulfur, and attention to the scalp for seborrhea. Then there is an entity known as neurodermatitis. It is caused by compulsive scratching due to psychological factors. Okay, that is why neurodermatitis. There will be intense itching, and the otitis externa bacterial type may follow infection of raw area left by scratching. Treatment is psychotherapy, and if there is any secondary infection, that secondary infection needs to be dealt with. Necrotizing or malignant otitis externa. This is a short note in itself. Okay, it is caused by Pseudomonas infection. usually in elderly diabetics or in those on immunosuppressive drugs. Its early manifestations resemble diffuse otitis externa, but there is excruciating pain and appearance of granulations in the meatus. Facial paralysis is common. Okay. The term malignant is because the infection will spread to the skull base and jugular foramen, causing multiple cranial nerve palsies. So anteriorly it will go to the temporomandibular fossa, posteriorly to mastoid, and medially to the middle ear and petrous bone. CT scan is useful to know the extent of the disease. And for treatment, we need to give high doses of IV antibiotics. Basically against Pseudomonas. Okay, so we give fourth generation cephalosporins, tobramycin, ticarcillin, or third or fourth generation cephalosporin for 6 to 8 weeks or longer. Diabetes need to be controlled. Devitalized tissues should be surgically debrided, and radical resections have been abandoned in favor of prolonged intensive medical therapy. So cefpodoxime is usually given, tobramycin, ticarcillin in high doses and controlling diabetes. Herpes zoster urticus. This is again another short note. Ramsay-Hunt syndrome. It is characterized by formation of vesicles on the tympanic membrane, meatal skin, concha, and postauricular groove. The 7th and 8th cranial nerves may also be involved. Pathology: the disease is a reactivated varicella zoster infection from dormant viral particles resident in the geniculate ganglion of the facial nerve and the spiral and vestibular ganglia of the 8th nerve. Clinical features: otalgia and facial palsy. 8th nerve may be involved, hearing loss, tinnitus, and or vertigo. Vesicles will also be present. Okay. Treatment is antiviral, acyclovir, and steroids. Now, foreign bodies of the external ear. Because the foreign bodies get lodged in the external auditory canal, this also comes as part of the disease of external ear. It is most common in children. The objects could be living or non-living. Okay, it may cause conductive hearing loss and it may cause inflammation. So basic idea is to remove in an atraumatic manner. So you have to minimize the injury to the external auditory canal by directly visualizing it. If needed, using an operating microscope. So this is an example of foreign body in the external auditory canal. So now removal of foreign bodies, okay? So there are some hooks which are known as foreign body hooks. So you put it beyond the foreign body and then pull it towards yourself. So you can also use Jobson-Hunts probe, the rounded end, and sometimes take the foreign body out. Okay, different types of forceps are there which could be used for removing different types of foreign bodies. Crocodile forceps, blunt hook, okay. Sometimes we need to do syringing, and sometimes we can also use suction machine in order to remove different types of foreign bodies. Now the tumors of external ear. So the tumors of external ear, first pinna. In pinna, there could be benign or malignant tumors. Benign ones include preauricular cyst or sinus, sebaceous cyst, dermoid cyst, keloid, hemangioma, papilloma, cutaneous HERN, keratoacanthoma, neurofibroma. And the malignant ones include squamous cell carcinoma, basal cell carcinoma, and melanoma. So I'll be briefly touching upon the malignant ones. The squamous cell carcinoma, the site usually is helix. It may present as a painless nodule or an ulcer with raised everted edges and indurated base. There could be metastasis to regional lymph nodes. It is very common in male in their 50s who had prolonged exposure to direct sunlight. It is common in fair complexion people. Treatment: if the lesions are small and there is no nodal metastasis, it is excised locally with a margin of 1 centimeter of healthy area around it. Larger lesions of pinna or those coming within 1 centimeter of ESC and lesions with nodal metastasis may require total amputation of the pinna, often with en bloc removal of parotid gland and cervical lymph nodes. So if it is small, 1 centimeter margin, local excision. If it is large, total amputation of pinna and en bloc removal of parotid gland and cervical lymph nodes. Basal cell carcinoma. The main sites are the helix and tragus, usually affect men beyond 50 years of age. So there will be a nodule with central crust, removal of which results in bleeding. Ulcer has a raised or beaded edge. Lesion often extends circumferentially into the skin but may penetrate deeper, involving cartilage or bone. Lymph node metastasis usually do not occur. Treatment: superficial lesions not involving cartilage can be irradiated and cosmetic deformity avoided. Lesions involving cartilage may require surgical excisions in cases of squamous cell carcinoma. Now the tumors of external ear: benign osteoma, exostosis, ceruminoma, sebaceous adenoma, papilloma, and malignant, again, squamous cell carcinoma, basal cell carcinoma, adenocarcinoma, malignant ceruminoma, and melanoma. So this difference is important, okay? Osteoma and exostosis. So osteoma, it arises from cancellous bone. Exostosis, it arises from compact bone. Osteoma is usually single, smooth, bony, hard, pedunculated tumor. Okay, exostosis is usually multiple, bilateral. It presents as smooth, sessile, bony swellings. Osteoma mainly from the posterior wall of the osseous meatus near its outer end. And exostosis, it is usually in the deeper part of the meatus near the tympanic membrane. So exostosis is usually seen in swimmers and divers. So it is related with continuous exposure to cold water. Treatment of both is surgical removal, but you need to know the difference between osteoma and exostosis, okay? Osteoma is solitary, exostosis is multiple. So everybody following till now?
Yes, sir.
Okay. Then we have a term known as ceruminoma. It is a tumor of modified sweat glands which secrete cerumen. It presents as a smooth, fine, skin-covered polypoid swelling in outer part of the meatus, generally attached to the posterior or inferior wall. It obstructs the meatus, leading to retention of wax and debris. The malignant type outnumbers the benign by 2:1 ratio. And the treatment, we have to be careful because the tumor has tendency to recur. And treatment is excision, okay? So this was my last slide for today, ceruminoma. And so this topic is big. This topic is a bit long, but there are numerous short notes which can be asked from this lecture class, okay? So I would suggest that you go back and read it for yourself from your book. So how many participants are there now?
110.
107.